In progress.
Assalamu alaikum, everyone. My name is Maryam Altayeb. I'm a final year medical student at Al Faisal, and today I'm going to be teaching you guys the physiology of optics. I know it might be a bit of a challenging lesson, but hopefully you can get something out of it, especially for those of you who wear glasses. So, Bismillah, let's start. So, we're going to be talking about the physiology of optics. Let me just put my laser pointer. All right, perfect. So, like I mentioned, a lot of people wear glasses, okay, myself included. And so it's very important that we understand. And some of you might have a prescription that says plus 2.5, others might have minus 0.75. So what does that mean? What is plus? What is minus? We're going to understand all of this today, inshallah. And first, my favorite part, let's start with a magic trick. So for those of you wearing glasses, I suggest you take them off. And there are 2 points on the screen. There is this sun with a dot in it and this X. So what I want you to do is cover your left eye and focus only on the sun with a dot in it. And then move your head until you see the X disappear. So magic, right? Well, it didn't actually disappear. That's just your blind spot. So your blind spot is the point at which your optic nerve actually inserts into the sclera, or the covering around your eye. And that's why I can't see anything. There are no photoreceptors there. So there's no signal to be transmitted to your brain for you to process. That's why they always say check your blind spot when you turn to the side. So some might call it magic, but it's actually just physiology. And so let's start with the basics. What does the eye look like and how do we see? So this is the eye. This is a beautiful picture of an eye. And so the iris is the part that most people recognize. That's the part that actually gives your eye color. But you have something that's covering it, like an outer layer, and that's called the cornea. And the reason we don't see it is because normally it's clear. And so you just see right through it. And then you have your pupil, which is this, or this black part. It's basically just a hole in your iris. And then behind the pupil is your lens, which you also can't see. All right. And then that is going to be your anterior segment of the eye. And then after that is the posterior segment, where you have your vitreous chamber. And here in the back, you'll have your retina and your choroid that we'll see in a bit. And so that's the colored parts of your eye, this black part of your eye. What about the whites of your eye? That's actually the sclera. So in continuation with the cornea, you have your sclera, and then your sclera wraps around the eye and provides basically a place for all of the muscles to attach to your eye. And so within the eye, it's not just dry all the time. You have different types of fluids. So in this anterior segment, you have your aqueous humor in the anterior chamber, as well as in the posterior chamber where the lens is. And you can see the angle between the cornea and the iris. That's very important for something called glaucoma that we'll talk about very briefly in the end. And here's your posterior chamber. So this muscle here, that's called your ciliary body, and that actually secretes this aqueous humor that allows for lubrication and nourishment of these parts of the eye. Because interestingly, the cornea and the lens actually don't have a blood supply, they're avascular. So people have even done transplants from cadavers to living human beings because these parts don't require a blood supply. Or you can easily transplant a lens to like a plastic one. And then in the back part, you have your vitreous chamber that's filled with vitreous humor, which is a thick fluid. But of course, all of these fluids are clear. Otherwise, you'd be able to see something here, and light rays wouldn't pass through as easily. So let's go through that again, just with a bit more of a detailed diagram. So this is exactly what we were seeing, the cornea. In continuation, you have the sclera, or the whites of your eyes. The iris is the colored part. The whole of the iris is the pupil. Behind it is the lens. Here you have your ciliary body. And here you have your choroid. So your iris, ciliary body, and your choroid actually form what you call your uvea. And the reason the choroid is important is it's vascular. So the posterior part here, this actually has a blood supply. Okay, and your retina is what allows you to see. So this is where you get your electrical signals that go to your brain that tell you, I'm looking at a tree, or I'm looking at a phone, or I'm looking at whatever it may be. And there's a part of the retina called the macula. And that's where you have your highest visual acuity, or think of it as if the other parts of the retina are like 480p, your macula is like 180p, and then your fovea of your macula, which is a very specific point, is like 4K. Like that is where you have your highest visual acuity out of anywhere else in your eye. Okay. And yeah, so basically those are the different parts of your eyes. But the reason I told you that the fovea is the most or the point with the highest visual acuity is because you have something called your visual axis. You can see AP is just talking to anterior, posterior. So this is if you cut like through the middle of your eye, all right? But the visual axis, or the way light is actually going to enter, is not going to focus on this spot here near the optic disc, which remember is your blind spot. It's actually going to tilt a bit to focus on the fovea, because this is your, remember, like 4K resolution portion of the eye. All right. So this is what happens. The light waves travel to the retina, where it creates electrical signals to go to your brain for visual processing. And this process is called phototransduction. Photo meaning light, and then transduction meaning it's being relayed to the brain. And so remember, your eye is like a camera. So this would be your pupil here. The iris is like a shutter. And so if you notice, sometimes your eyes are dilated, sometimes they're constricted, and we'll see why in a little bit. And in order for you to see something, it has to focus directly on the retina. If the image focuses before the retina, after the retina, it's going to be blurry. Think of it like a projector. Usually your projector has to be at a perfect distance from the wall for you to be able to see the image or the movie or whatever you're watching properly, right? So same thing applies here. If it's too close or too far, it won't be a focused image. Of course, your eyes have mechanisms in order to shift for you to understand what you're seeing and have your vision not be blurry. But in order to do that, you need to have different changes with the lens that we're going to learn about today. But it's the same concept. It's like if the projector is too far or the projector is too close, the images will be blurry. And so now let's talk about refraction and lenses, because in order for us to understand the different pathologies, we need to understand how light actually travels and how that works. So although this looks like a Pink Floyd cover, it's actually showing us something called Snell's Law, and it's not as boring as it seems, okay? So what Snell's Law states is when light travels from an area of lower density, such as air, to an area of higher density, like plastic, water, glass, your eye, for example, that light is actually going to bend. It's not going in a straight line. Okay, and this process of light bending is called refraction. So this is how lenses work, and this is actually how we see. So this is, again, same thing, but this is just the slide from your lecture. By the way, all the slides I tried to keep. I just rearranged a lot of things so you guys can understand it as clearly as possible, inshallah. Okay, so if this is angulated, okay, whatever medium the light is passing through, this angulation is going to lead to refraction. It means that the light is not going to pass straight through it. It's going to pass into it at an angle if the surface is basically not perpendicular to the wave itself. Okay, so why is this important? Well, this is how your eyes work. Remember when we saw the cornea? It's not perpendicular to the way light is going. It has a curve to it. It has an angulation. And that basically causes the light rays that are going into your eye to tilt inwards and be able to focus on your retina for you to see properly. So we have something called the refractive index, which is measuring how fast something travels in air, or light travels in air, versus how fast it travels in that surface. And we're able to calculate an index from this. And the reason we care about this index in the first place is that it allows us to measure how strong a lens is. So for example, when light travels and then hits the cornea of your eye, that's actually the strongest lens in your eye, not the actual lens. And we'll see how that works in a moment. But we measure that by the refractive index. And so remember the prism that I showed you that isn't actually a Pink Floyd cover? I want you to just pay attention how light is bending with this prism. It's going downwards, right, after it exits. And we can actually use this to our advantage. We can, basically the way glasses work, the way lenses work, is we take this principle and then kind of stack them on top of each other and allow the patient to have a focus that is on the retina. And I'll show you what that means in a second. So let's say you have these two prisms, okay, and you stack them on top of each other. This is the way the light rays are going to go. And remember, it's going to go downwards. And this one is flipped, so it's going to go upwards. And so what happens is you're putting them towards a point. It's like a magnifying glass. Okay, and this is what we call convergence. So some of you guys might have prescriptions that say +5 or plus 0.5. And so what plus means is it's basically a convergent lens. It's like a microscope. It's causing the light to be focused more closely on your retina. It's making your lens stronger. But obviously, we're not just going to put two triangles, two prisms in front of everyone's eyes. We're going to cut this out of glass. And so it's going to end up looking like this. Same thing. This is basically prism A and this is prism B stacked on top of each other, but it has a curve. And so this outward curve like this is called biconvex. Okay, why is it biconvex? Bi just means two, and convex is referring to this shape. So it's just saying that you have something that looks like this. They're stacked next to each other. Okay, and what this does is, remember, if this is a prism, the light is going to go downwards. So this allows you to focus light on a focal point that's much closer. Remember, this looks like a magnifying glass, basically. And so this is increasing the power of your lens. That's why we put a plus in front of it. So if someone has hyperopia, which is basically they're very far-sighted, what happens is the light is going to focus actually behind the retina. Their eyes are smaller and usually weaker. And so what happens is if you put basically a magnifying glass in front of it, the light is going to focus at a much closer point, aka the retina, and then they'll be able to see an image that is not blurry. And I'm going to go through these in detail, don't worry, towards the end of the lecture. So if you didn't catch it now, it's completely fine. All right, now let's do the opposite. Same prisms, same principle. Let's just flip them. Okay, so here, if the light rays pass, instead of going inwards, they're going to go outwards, right? Because remember, if this is the prism, the light is going to go down. And so this comes from the word divergo, which means to bend away from or go in a different direction. And so this is divergence. Okay, so it's going away from something. And so this is what we call minus lenses. So if your prescription is -2, for example, this is useful because some people have very big and strong eyes, which are what we call myopic eyes or myopia. And in myopia, it's the exact opposite of hyperopia. These are nearsighted people, so they can see things close up very clearly, but they can't see far. You know, so when I say farsighted, I mean I can see far, I can't see near. If I say nearsighted, that means I can see near, I can't see far. All right. And so in this case, if the eye is too strong, we want to weaken it. So we want to cause the light rays to disperse, which is why that's why we use actually these divergence lenses. But same as the other one, I'm not going to put two prisms in front of a person's eye. I'm going to turn it into a lens, into something smooth. And this is what we call a biconcave lens. So again, bi meaning on both sides. If convex is this way, concave is like this. It's the opposite. It's almost like it's caving in, okay? And so this type of lens focuses light on a farther point, okay? And this is used to treat myopia, like I just mentioned to you guys. So this is just how we look at it. So this, remember, is like your magnifying glass. Your biconcave is going to focus light closer, nearer. It's the plus lens, the magnifying power, okay? Your biconvex lens is your minus lens. That's going to allow you to focus light at a further point. Okay, and so that's just the different types of lenses. But what we just talked about, those convex and concave lenses, are spherical lenses. So they refract light in all planes and cause them to focus at a single point. But those are good for simple myopia, hyperopia, which again, don't worry, we're going to talk about them later. But you have a problem called astigmatism, which is basically when the eye or the cornea of the eye is shaped weirdly. So you get focal points at multiple different places. It's not just too close or too far. And so the way you fix that is you use a cylindrical lens. So it's like a cylinder, which is this shape here. And it doesn't allow it to focus all at one point. Instead, it allows it to all focus on the same plane, on the same line. So instead of a single focal point, you get a focal line. And some people have astigmatism with a myopia, hyperopia, like me, for example. Both my eyes have astigmatism, and I have the same, I'm plus 0.75 in both eyes. But because of that, what you essentially do is you stack these different types of lenses. You stack a spherical lens with one of the convex or concave lenses, and that's what they do. That's why you go to the doctor's office. If anyone just had simple myopias and hyperopias, you could basically do this all yourself. And this is just what it looks like when you have your cylindrical lens. So you see how it's focusing all these different rays at one specific line. So that's your focal line. And so I just wanted to show you that a bit closer up. And that way we're done with the first part. We're done with the basics and most of the principles. But now we're going to talk about something called accommodation and visual acuity. All right. So remember, like I told you, the human eye is a camera. So you have your iris, your pupil, and the film on the outside is your cornea. All right. And remember, our visual axis is at an angle so that it hits the fovea of your macula specifically, because that's your 4K vision right there. Okay. And the interesting thing is that this iris has muscles that can either contract or dilate the pupil. So contraction basically means you're making it smaller, and that's a process called meiosis. Okay. And that's controlled by your parasympathetic nervous system. If it's dilated, that's called mydriasis, and that's controlled by your sympathetic nervous system. And the way I like to think about it is parasympathetic is rest and digest. So if I'm resting, I don't need to see a lot. So my pupils are going to be small. I don't need to let that much information in. I'm relaxing. But if I'm in fight or flight response, think of it in terms of, our ancestors were being chased by wild animals and whatnot. So they're running. They're fight or flight. So they need to take in all the environment around them. They need to see really far. So their pupils are going to dilate to let the most amount of light and visual stimuli in possible. So that's how I like to remember it. So sympathetic is dilated pupils. Parasympathetic is constricted pupils. And so you can see specific things like cocaine abusers. That cocaine causes your pupils to dilate, for example. Okay. And remember those numbers that I was telling you about. Let's say someone has +2 or +1 vision. That one, what does that mean? That's something we call a diopter. So a diopter is measuring how powerful a lens is. So for example, okay, if I tell you this lens is 1 diopter, meaning, let's say I have +1 lens prescription. Okay, what that means is this 1 diopter lens is going to focus light perfectly at 1 meter, which is right here. My 2 diopter lens is stronger. It's going to focus light perfectly at 0.5 meter. A 3 diopter lens, for example, is going to focus light perfectly at 1/3 of a meter. So you see how we go from 1/1 to 1/2 to 1/3. 4 diopters would be 1/4, and so on and so forth. Okay. And so the reason 3 diopters specifically is important is because 33 centimeters is usually the distance at which people read. And so you'll see that as people age, we have a process called presbyopia. We'll talk about that later. Basically, the lens is not able to accommodate anymore. It's not able to focus any closer or become any stronger. And so because of that, you might see your parents have just glasses for reading, but everything else they can see normally. And those prescriptions usually are +3, so they allow people to read comfortably without straining their eyes. Okay, and I'll explain more about that later. So again, don't worry if you didn't catch the new medical terms I just mentioned. But again, basically, the bigger the diopter, so +5 versus +1, +5 is much stronger because it's like a magnifying glass. Because as you can see here, when we talk about positive diopters, I'm talking about our convex lenses, the ones that go outwards. Okay. Remember, our minus lenses are our concave lenses that are going to cause the light to disperse more. Those are for very strong eyes. All right. And so the way we calculate it is basically what I just mentioned. Sorry. It's not working for some reason. Okay, here we go. So the refractive power of a lens in diopters, or how strong or powerful a lens is 1 meter, which is, 100 centimeters, over the focal length. So again, this is inversely proportional. So anything that's, let's say, 10 diopters is going to be 1/10. okay, and so on and so forth. And remember how I told you the cornea is the strongest lens in the eye? Although it's not called the lens, it actually is the strongest because remember the refractive index that I talked about earlier? The difference between the way light travels in air versus the way light travels in the cornea is so drastic that it causes this cornea to have the strongest power in the whole eye. But then if you notice, the difference between the aqueous humor and the lens is not as much. And so because of that, the lens is, of course, important and it has its power. However, the strongest in your eye is actually going to be the cornea, which you can see here. So the cornea has a strength of 40 diopters. However, your lens only has a strength of 20 diopters. But overall, your eye has a total power of 20 diopters. And so like I mentioned, if I had a 1 diopter lens, it's going to focus light perfectly at 1 meter or 100 centimeters. 2 diopter lens is going to focus it perfectly at 50. 3 diopters is going to focus it at 33 centimeters, and so on and so forth. Okay. And all right. And so now let's talk about accommodation. So one thing first that I want you guys to keep in mind is when light is coming from a very far source, it has a lot of time to travel. So it's traveling to you in parallel rays, okay? Meaning they're basically going like this. They're not moving at any angle. They're parallel to each other. And as the light from a source gets closer to you, those rays aren't going to have enough time to be perfectly straight and parallel. Instead, they're going to be divergent. They're going to be going outwards. And because of that, your eye responds differently to the way it's going to take in these visual stimuli. So remember when I told you if you have your sympathetic nervous system activated, your pupil is dilated, you're looking really far. Okay, so with this far vision, what happens is your lens becomes flat, okay, and your pupil becomes more dilated to take in more information. So if you're in a clinic, for example, one of the things we do in ophthalmology is before we start testing the eyes, we tell the patient to look at the wall or look at a far point because we want to see what is the natural resting state of the eye. Is it able to dilate? Are they able to see at that distance? Okay. However, as you bring something closer, and you can test this on yourself or your friends or your siblings, as you bring, let's say, this pen in the clinic, you would ask a patient to do that. You'd ask the patient to look at this pen and stop when they start getting double vision. Okay, so for me, that's about here. And usually it's about 9 centimeters, and then it gets long, like the distance becomes more as you age. But what happened? I'm going to try to come closer so you can see. So a couple of things happened. One, my eyes moved inwards. It's like if you ask someone to look at their nose. Your eyes are going to move inward or converge, okay? Your pupils are going to constrict. Why are they constricting? Because you're trying to limit the divergent light rays. You're trying to focus it so that it can hit your fovea properly. And I'm going to show you a video in a second that explains this much better. Okay? And the thing that you can't see is that your lens is actually going to become fatter. It's going to try to become more powerful because remember, you want to have more diopters as something is coming in closer and less as you're looking further away. Okay, so you have roughly about like 14 plus minus change in diopters with accommodation. And so this is essentially what's happening. You're increasing the refractive power of the lens. As something becomes closer, it's almost like your eyes are zooming in. You're trying to make it more powerful. Okay. You're converging the eye, you're looking inwards, and you're constricting your pupil, which is known as meiosis. And all right, so I'm going to show you guys this video that explains the whole process of accommodation. So how your eyes would refocus from looking at a distant object to looking at a near object. And hopefully the visuals will help really hammer these points in. All right, will it decide to work? I hope so. Hello. All right, there we go.
As an object approaches, both eyes track it in a process called convergence. The size of the eyes in this example has been greatly exaggerated so that the sun takes place during convergence can be seen. Convergence of the eyes keeps the image of the object centered on the fovea. Resolution is highest. eyes do not converge appropriately, diplopia, or double vision occurs. Second, the pupil must constrict to restrict the entry of light rays diverging from a near object, since diverging rays cannot be bent enough by the periphery of the lens to make them fall on the fovea. If the pupil were to remain dilated, the image would be blurred.
This is the point, and that's why you constrict your eyes when you accommodate, when you look at something.
Finally, the shape of the lens must change, increasing its refractive index so that the light rays passing through it converge on the fovea. In distance vision, the lens is pulled at its equator by the suspensory ligament so that it is relatively thin. When the muscles of the ciliary body contract, the tension on the suspensory ligament decreases, and this allows the lens to assume a rounder shape, increasing its power to bend light.
See how it's
As a
sharper
result,
now?
the image is focused on the fovea.
That's the goal. That's why accommodation happens, basically.
Convergence. Pupillary constriction. Rounding up of the lens. All function to keep an object in focus as it approaches the eye. Okay. We're gonna ignore the nursery rhyme music, but basically that's how it works. That's why you accommodate. So you see how those three things together, basically converging the eyes, constricting the pupils, and fattening up the lens, that's all accommodation. And so the reason this happens is, like I mentioned, so that you can focus on objects that are closer because they have diverging rays of light, as opposed to further objects which have parallel rays of light. And so when you look at a further object, your lens is flat. And when your lens is flat, usually the ciliary muscle is relaxed and your zonules are tight. It's like pulling it apart. Okay. In accommodation, however, when you're looking at a near point, it's the opposite. So your ciliary muscles are contracted, your lens is fatter, and because of that, those suspensory ligaments are relaxed. But what's important, and what they can ask you guys in MCQs, is that the anterior surface of the lens is actually what's changing. The posterior surface doesn't change much. So it's the anterior surface that is being altered in order to accommodate, okay, in order to let those light rays focus directly on the fovea. Okay, and that's what I tried to mention earlier, is that you usually have like an accommodation allowance of about 14 diopters. And in children, usually the refractive power can go from 20 diopters around 34. Okay. So this is near versus far vision. So you can only see an object clearly when its images or its light rays are directly focused on the retina. And so this is a really great side-by-side comparison. You can see how in the relaxed state, your lens is unaccommodated. It's flat. These fibers, these zonules, actually, that's what they're called, are taut, they're tight. There's tension on them, and your ciliary muscle is relaxed. However, in accommodation, it's the exact opposite. Ciliary muscle contracts, these fibers relaxed, and it basically lets the lens fill up more space. It allows it to expand. And yeah, so this, again, they can also ask you guys these in MCQs. What are the differences? So make sure to know them very well. Okay. And in the relaxed state, parallel rays are coming in. Accommodated state, more divergent rays are coming in, and you have constriction of the pupil. All right. So these are different terms that can help you guys understand. So far point is basically the furthest distance at which an object can be seen clearly by the eye. Usually this is 20 feet or 6 meters, which is why we use this distance when we test for visual acuity, which I'll show you in the next slide. Your near point is the nearest distance at which an object can be seen clearly, usually 25 centimeters or 10 inches. So how clearly can you see this object? Because, if you keep going, it's just you're gonna have double vision. You're gonna be cross-eyed. Okay, so that's your near point, and your near point usually gets further away with age because your lens is not able to accommodate as well. And then you have your amplitude of accommodation. So basically, it's the difference between the refractive powers of the lens with ciliary muscles. So maximally contracted, you can add about 29 diopters. Completely relaxed, you can add about 15. Okay. So the difference between these two is about 14 diopters, as we mentioned earlier. Okay, here we go.
So have you guys seen this before? I have, definitely, in the doctor's office, in film, you see it everywhere. It's called a Snellen chart. And although we see it everywhere, it is only recently that I completely understood what these numbers meant. And so remember what I told you? The far point is usually 6 meters or 20 feet. So that's what these numbers stand for. So in a very simple way, you keep this at 6 meters away from the visual axis of the patient, from the patient's eye. There's a 6-meter distance between the eye and the Snellen chart. And obviously, without wearing glasses, you're going to ask the patient to tell you what the first letter is. Okay, and then after that, what the second letter or second line of letters is, and so on and so forth. And these numbers on the side basically represent the distance at which a normal person can read them. So when I say I have 20/20 vision, what 20/20 vision means is a person with normal vision can read these letters from 20 feet away or 6 meters, like it's like 20/20 or 6 out of 6, depending on if you're in meters or feet. Okay, so if I can only read up to here, they'll tell you, oh, the normal person can read this from about 30 feet. This one, the normal person can read this from about 40 feet, and so on and so forth. So a normal person would be able to identify this E, or that this letter is an E, accurately and with clear vision, not blurry vision, from about 200 feet away, okay, or 60 meters. So this point, okay, means that basically it's the way we measure how strong a person's visual acuity is, or how well they're able to see. All right. So 20/20 or 6 out of 6 means the eye has full refractive power because it's 60 diopters at 6 meters. And remember what we said before, the formula. So the refractive power of a lens in diopters is 1 meter over the focal length, or 1/6. So this would be our 60 diopters. And so this is what it looks like. Basically, your patient would be sitting here, and this is the visual angle that we're looking at. So this is the distance, 6-meter distance between the eye and whatever letter they're looking at. And so the reason this angle is important is, you can see it here. So it's basically, is the patient able to identify all the individual components of these letters? Are they able to separate them? Because if they're blurry, they're basically all going to go into each other, and they're not going to be able to identify that. Okay. I'm going to go to the next slide. I'm skipping over anything that is just extra information, so you know. So this is just explaining to you what a Snellen chart is. Each of these letters is going to fit into an individual square, and they all have basically precise measurements. And this is what I explained to you guys. Okay, so first letter is at 60 meters distance that you should be able to read it. Second is at 36, third is at 24, etc., etc. And that's what those small numbers are. Okay, so how is visual acuity measured? This is what I just showed you guys. It's determined using the Snellen chart. So the little d over the big D are these numbers. So small d represents what distance am I reading the characters from. And the reason this is important is because, let's say I can't read anything from 6 feet. There are different tests that can be done, but one of the things that the doctor might do is ask me to come closer. So let's say at 4 feet or 5 feet, and see if I'm able to read it. So then this number would change. Instead of being 6 over whichever, it will be 4 over whatever number, if it's in meters, or another number if it's in feet. Okay, so this larger number is the distance at which the characters should be read. So at what distance does the normal eye identify these with full clarity? And what you're going to do is you're usually going to test one eye at a time, so preferably your right eye and then your left eye. And your vision is 20 out of 200 if only the top line can be read. And so why do we care about this? One is, identifying if patients have any specific types of errors, but we have machines for that. Number one thing is that Snellen chart is very easy. It's very accessible. You can even have a pocket version of it. And especially if you're in something like an ER and you have someone coming in with eye pain or visual changes, Maybe they have a glaucoma, or you guys just took neuro. So maybe this patient is coming in with multiple sclerosis, and one of the early presentations is optic neuritis or inflammation of the nervous tissue in the eye. And when that happens, they can lose vision because their optic nerve is not able to receive input as well, and that can lead to blindness. So with just a simple Snellen chart in your hand, maybe you can identify this patient that has 20/200 vision and immediately get them treatment and prevent them from being blind for the rest of their lives. So that's why it's very important that we know and understand how to use these and how to report these things. So again, normally your vision should be 20/20 or 6/6. And let's say patient can only read or can't read any distance. Okay, they basically could not get here. They couldn't get this 20/200. What now? What can I do? You're going to do other tests, things like confrontational visual fields. So you're gonna basically make sure that the patient can see. Can they perceive light? Can they not perceive light? At a distance, can they say, for example, I have 3 fingers, 4 fingers, 5 fingers at different distances? If not, can they see hand motion? Are they able to identify that my hand is moving or not? Can they see, is there light? Is there no light? So this helps you identify how visually impaired this patient is. And so you probably have heard the term legally blind. So when we say legally blind, it's basically a term used to identify who is eligible for disability benefits in the United States. But based on these different numbers, you can identify the degree of visual impairment that a patient has. So if I'm only able to read above this, so basically if I'm able to get here, then I have mild visual impairment. If I have less than this, then I have moderate. If I have worse than this, then I have severe visual impairment. So it's just a way to identify the different categories of this patient. So when would I say a patient is totally blind? Okay. Totally blind is basically, I tested this, the patient couldn't even identify this. I said, okay, I'm going to do my other tests that I just talked about. I'm going to counting fingers, can't see anything. Hand motion, can't see anything. Light perception, can't see anything. No light perception or NLP means this patient is totally blind in one eye or both eyes, depending on your testing. Okay. So now we're on to the important part of the lecture, which is refractive errors and astigmatism. So now you guys are going to understand how you see or do not see. Okay, so you have different types of refractive errors. Some are physiological and some are pathological. Why do we say they're physiological errors? Well, sometimes you can have blurry vision at night, for example, or with children can have specific errors. And that's just simply because, for example, children have smaller, weaker eyes, so they can have eyes that are more hyperopic. Okay, and you have 3 different things in physiological. You have spherical aberrations, chromatic aberrations, and diffractions. But what is most important for you guys to know are the pathological states: myopia, hyperopia, and astigmatism. So I'm going to go through the normal, and then we're going to start to understand the abnormal from there on out. So remember, this is what I explained to you guys earlier, where you have to have your image at a specific distance that allows you to focus light directly on the retina, specifically the fovea. And from there on out, you're going to process that as visual information. Remember, it's like a projector. If the image is too close and you're unable to focus, or too far and you're unable to focus, then you're not going to be able to see anything. It's going to be blurry. Okay. So these are our physiological refractive errors. Spherical aberration basically means that you see how all these lines are overlapping at weird places here. Your light rays are not focusing on one specific point, and sometimes this can happen when you're in dimly lit rooms and things might be a bit blurry. The similar thing happens in chromatic aberration. So this happens with light. So you have your light gets refracted earlier, and so you have blue rays at a point and red rays at a point, and the color spectrum is everywhere in between. So these blue rays and red rays are going to be focused at different points. But the key thing here is that these are focused before the retina. Okay, so that's why you might get different colors that you see. And then last but not least is diffraction. So diffraction is what happens when you bend light rays, okay, over the sharp borders of the pupil. So when you have very small pupil, it might interfere with the way that light is entering your eye. Remember, that's why you constrict your eyes when you're looking at something close. But let's say a patient has eyes that are constricted. Like let's say you just shined a light in their eye for some reason, and they try to look far. When you shine a light in someone's eye, as a reflex, that's going to cause your pupil to constrict. And you try to look far, the light is not going to enter your eye properly because it's not dilated, it's constricted at that point. So that's when, diffraction comes into play, when they have a small pupil size, okay? Or, subhanAllah, congenitally, some people have smaller pupils than others, so they might have difficulty, not necessarily because it's pathologic or there's something wrong like myopia, hyperopia. It might just be the size of their pupils. So this is a video to explain spherical and chromatic aberrations. I'm not going to go through it, to be honest, but it is interesting, and he does show you how everything works. So if you are interested, please give it a watch. It's just a short 5-minute video. But now to the important part, the pathological refractive errors. So I started to mention this earlier, but I'm going to go through it again. So these are probably the most common things you will see. You can walk around uni, especially in medicine, and you'll see everyone wearing glasses. Everyone is going to have a refractive error, okay? And so there's two main ones, hyperopia and myopia. And so what happens in hyperopia, this is when you have a patient with very weak eyes, usually smaller eyes. You can also see this in children. And so what happens is because the eyes are weak, they're not able to focus that well. So the light rays end up focusing behind the retina. See, this is the retina here. End up focusing behind the retina. And because of that, the image appears blurrier. So how do you treat that? You give them a more powerful lens, a plus lens. That's going to be, remember, the one that goes out, our biconvex lens. And so this biconvex lens is going to add power and allow you to focus light right here. Okay. And myopia is the exact opposite. It's when you have a patient with very big, strong eyes that are way too strong. So it focuses light before it even hits the retina. So you can see how this eye is elongated in comparison to this one. However, how do you correct it? With a biconcave lens. So it's going to diffuse the light and allow it to focus here at a further point. So this shows you how this eye is maybe a shorter, weaker eye. A longer eye would have myopia. طيب, what about normal people? Normal people or normal eyes are what we call ametropia, just meaning that it's perfectly fine. It will focus light on the retina exactly without a refractive error. So myopia means you're nearsighted. So just from the name, nearsighted, meaning I can see near. So in myopia, remember, these are the very big, strong eyes. So the eye is too long for the refractive power. So your lens ends up focusing light before it hits the retina, as you can see here. And in order to correct it, you're going to use a concave or diverging lens to disperse the light more and allow it to focus on the retina. So the way I like to remember it is for myopia, I say, I like to keep my things close to myself. Okay, so my things, meaning myopia, close, meaning the light focuses way too soon or way too close in front of the retina, okay, to myself. So when I say to myself, I'm kind of caving inward. So that's how I remember that it's a concave lens, okay? What about the other way around? What about hyperopia? So hyperopia is the exact opposite. It's when everything is going to go further. The eye is weaker, it's shorter. So what ends up happening is that light focuses behind the retina. So the axial length of the eye is too short for the refractive power. So how do you fix that? You need to give them a magnifying glass in order to focus the light sooner. And so this is what we call converging lens. And so the way I remember it is I say hyper people are running far away and they annoy me. I'm sorry to anyone with ADHD. But I remember hyper people, so hyperopia, are running far away, so they focus like behind, further away, and they annoy me. So the reason I say annoy is because another word for annoy is to vex someone, so convex lenses. So yeah, that's how I remember these two. And I hope this clarifies it for you guys. So these are the simple refractive errors. And believe it or not, I learned that I had a visual problem because of this meme, which is so stupid. But essentially, I always thought it was normal that people would see lights with these parallel lines, but apparently it's not. And it's something called astigmatism. And so, what astigmatism is when you have abnormal curvature of the cornea. Basically, this happens. So, this is how the cornea normally is. It's curved in this shape. However, an astigmatic cornea is more cone-shaped. And so what happens is instead of having one focal point like you do here, you end up having multiple focal points at different places. And so this is a problem because it's going to cause lines in a distance to be blurry and lights to appear with that linear pattern as well. And so if you guys remember from earlier, the way we treat this is cylindrical lenses. You can't I mean, of course, you can do surgery later on to change this, but your goal now is not to have one specific focal point like we did with myopia and hyperopia. It's to make sure that all these different focal points are aligned in a focal line. And so that's why we use our cylindrical lenses. So you can see how here, for example, they're all in different places. You would see it in this way. And remember, people can have astigmatism and myopia or hyperopia like I do. It's not just one or the other. And so this is actually how I see the world, interestingly enough. So people with astigmatism, like myself, when you look at a distance, you won't be able to see all lines as clearly, or you'd see lights in this way, as opposed to someone with normal vision. And so how would you test it? Usually this is the astigmatism testing chart that is used, and you tell the patient to stand 2 meters away and you ask, are there any lines that are clearer than the others? Because if you look at this one, the example I showed you guys of the Golden Gate Bridge, you can see that some lines that are thicker are clearer than others. And so if that is the case, that will tell you that there's astigmatism because the way the light is entering the cornea, because it's abnormally shaped, you'll have different focal points. For example, here, there's this focal line and this focal line, and you would get the cylindrical lens in order to correct it. So yeah, I hope this was helpful and that you didn't have to, figure out that not everyone sees the world that way. Okay, so this is one of the most truth things I came across. And I always thought it was normal that like my mom would just look at things like this. But I realized over time that this is just a normal process of aging. And if you guys remember what I told you earlier, the near point of vision, that's usually about like 25 centimeters, gets longer or like further and further and further away with age. And the reason that happens is due to something called presbyopia. So presbyopia is basically the lens itself hardens with age. And when it hardens, that means you're not able to accommodate. And remember, accommodation is what happens when you bring objects closer to you. So if you're not able to accommodate, you'd like to have whatever glasses or whatever thing you're reading at a specific distance in order for it to be clearer. And so that's why our parents, look at things at that distance. It's more comfortable for their eyes without straining. And you might notice that over time, they start to look at things at a distance and start to squint as well, or squint when they're reading. And so in order to prevent straining of the eyes, what we do is we usually recommend bifocal glasses. Your parents might have that, your grandparents, and it's usually about +3. And remember, the reason it's usually at +3 is because you tend to read at 33 centimeters away from your face. And so +3 is 3 diopters. And so that's basically what allows them to read comfortably without straining their eyes. And so this is what happens. So normally, the image focuses on the retina. But when the lens is weak and unable to accommodate, unable to add that increased power, those increased diopters, the image ends up focusing behind the retina. Okay, and this is like hyperopia. Remember, hyper goes far. So what happens is it ends up being blurry, and then they end up needing glasses because of that. So it's similar to hyperopia or farsightedness. But there's a very interesting thing. Okay, let's say a patient has myopia. Remember, with myopia, you're going to focus in front of the retina. And then with age, they get presbyopia. So they focus behind the retina. What happens is these two things kind of cancel each other out. And then as a compensation, the image ends up focusing on the retina. And so they call it a second sight. So a pre-existing myopia may temporarily compensate presbyopia, leading to better near vision. So that's why they call it a second sight. And this was actually a UWorld question I got very recently. So for those of you preparing for your steps, make sure to know this. And so the treatment of presbyopia is going to be the same as the treatment of hyperopia. So you're going to get convex lenses because remember, you need a magnifying glass basically to help focus the image back on the retina accurately, or they can eventually get refractive surgery that would correct any errors. And last but not least, the last part of this lecture is talking about aqueous humor. So remember, aqueous humor is the clear fluid that fills the anterior chamber, okay, and the posterior chamber. So here and here. And it's secreted by the ciliary body. And remember, the ciliary body also has a ciliary muscle that contracts for accommodation. And so it's produced by diffusion and active transport from the plasma. And it's very important because it's nourishing these structures in the anterior chamber. And remember, the lens, the cornea, these are avascular structures. They don't have any blood supply, so it needs to get its nourishment through these mechanisms. But what I want you guys to focus on is how it's moving. So it's being produced in the ciliary body here. It's going to go through here into the anterior chamber, and then it's drained over here in the canal of Schlemm. Okay, and this is very important because this is where over 90% of your aqueous humor is drained back, and your eye has a pressure, right? Any fluid in a compartment is going to create a pressure. And if you have any blockage here, especially acutely, remember the angle that I told you about, the angle between the cornea and the iris, or the iridocorneal angle? If for some reason it gets closed, it gets blocked off, like where my pointer is here, you're not going to be able to drain the fluid in the eye. And suddenly pressure is going to build up. And imagine how painful that is. Your eye's literally bulging out and stretching. And so that's what we actually call glaucoma. So glaucoma causes degeneration of the optic nerve due to increased intraocular pressure. So like I mentioned, fluid in any compartment is going to create pressure. And when you have pressure in your eye, normally it's from 12 to 20 millimeters of mercury. And you measure it by this device here called a tonometer. Okay. And there's one that does it with like basically like puffs air into your eye, and then it's going to measure intraocular pressure that way. But what happens with the tonometer is it measures this. And if it says, for example, you have very high intraocular pressure, this patient can get glaucoma. It can happen acutely, chronically. I believe you guys have a pharma lecture about that. I also have a pharma table about glaucoma drugs that you guys can go over. But yeah, it's acutely can be very painful. And so usually patients will present to the ER and hopefully get treatment to prevent blindness. But the thing that is very important is that this can happen as a chronic process. People can have a glaucoma and not know that they have elevated intraocular pressure for an extended amount of time. And because of that, it can basically cause them to be blind incrementally over time until it's too late. Your optic nerve has already atrophied. You can't get it back. Nervous tissue doesn't regenerate that way. And so it's very important to get checked and tell your parents to get checked, particularly if they have diabetes or any other comorbidities. It's very important to get them checked for glaucoma. And it's a very quick process. It literally does not take time. And treatment is simply eye drops, among other things. But usually for chronic cases, we go for something like timolol. All right. So I hope everything was clear. Now we're going to go through some questions. These are all questions I got from the Guyton review book. So they're all based on the physiology concepts that we talked about today. And I hope you guys find them helpful. I'm going to read through every question and then explain each answer. Okay, So a 10-year-old boy looks at ants through a magnifying glass. So remember, magnifying is like a biconvex lens. He finds that the ants must be at 10 centimeters from the convex lens to be in focus. Which value best describes the refractive power of the lens in diopters? All right, so remember the refractive power equals 1 meter, okay, over the focal length, which is this, okay? So 1 meter is the same as 100 centimeters over the focal length, which is 10 centimeters. So it's basically saying 100, right? 1 meter is 100 over 10, okay, equals what? 10 diopters, if you cancel out the zeros. So the refractive power of this lens is thus 10 diopters. So that's just how you solve this question. It's very simple based on this formula, but so long as you know it, it'll be very simple. And just always, of course, remember 1 meter is 100 centimeters in case you get confused. Okay, so now which of the following best describes the blind spot of the eye? A, located 5 degrees lateral to the central point of vision. B, the exit point of the optic nerve. C, only contains rods and thus has monochromatic vision. D, contains no blood vessels. Or E, the area where the chromatic aberration of the lens is the greatest. Okay, so from the little experiment we did in the beginning, or the magic trick, we know that the answer is B. So the blind spot is basically where the optic nerve exits the eye. And it's not 5 degrees, it's actually 15 degrees lateral to the central point of vision. Okay, and it's the point where the optic nerve enters the eye / exits the eye, so the optic disc becomes the optic nerve. And there are no photoreceptors. That's why it is a blind spot. You can't see anything, okay, at that specific point. So now this question. A 25-year-old student with 20/20 vision looks up from his book to view his friend sitting on the other side of the room. Which of the following is most likely to occur when the student changes his view from his book to look to his friend? So essentially, this guy is looking at something close, and then he looks far. So when you're looking at something close, you're accommodating, right? Your pupils are constricting, you're converging a little bit, and your lens is thicker, your ciliary muscle is contracted, your zonules are loose. When you look at distant objects, the opposite happens, right? Your lens becomes flat, your ciliary muscles relax, your zonules are tight, and your pupils dilate a little bit. So of that, which would be the correct answer? So it's when you're looking far, you have a thinner lens and your ciliary muscle is relaxed. If I asked you the opposite, what changes when the person looks from a distance to his book, then it would be A, thicker lens, contraction of ciliary muscle, because that's accommodation. All right. Now, an 85-year-old woman visits the ophthalmologist because of difficulty seeing. The patient is given an eye examination and bifocal lenses are prescribed. The physician notes that the lenses of her eyes are clear. The woman sees well with new prescription glasses. Which of the following most likely describes the vision problems in this woman? Cataracts, glaucoma, hyperopia, myopia, or presbyopia? So in order to solve this question, let's recognize a couple things first. One, this woman is 85, so she's older, meaning that she most likely has stiffness of her lens, okay? Why did they mention that the lenses of her eyes are clear? Because if they were cloudy, then she would have difficulty seeing because of cataracts, أو نسميها بالعربي الموية البيضاء, okay? Meaning the white water, or when basically you get opacification of the cornea because of changes over time. So it's not cataracts, it's not glaucoma. She hasn't had optic nerve atrophy. There's no acute presentation. And glaucoma, by the way, نسميها الموية الزرقاء, because children, when they're born with glaucoma, they tend to have bluer eyes in the cornea. I don't know if you guys can hear that. It's very windy outside. Anyway, hyperopia and myopia. This could be the case with this patient. However, it's not as likely considering her age. So because of the degenerative changes, the answer here is presbyopia. Okay, and so like we mentioned, usually you have about +14 to accommodate, and That's for a child with good vision. Usually at 70 years, the lens completely loses its ability to accommodate. And so we say the person has presbyopia when their accommodation power is 0. Okay, and this is just, again, to show you what how that happens. Normal, your image focuses on the retina. Presbyopia, because of impaired accommodation, your eyes focus behind the retina, or the image is focused behind the retina. And the way you correct it is with convex lenses. So the ones that go this way. So basically a magnifying glass. All right. When parallel light rays pass through a concave lens, which of the following will occur? So remember, concave is the one that goes outwards like this. So the rays will converge towards each other. The rays will diverge away from each other. They will maintain a parallel relationship. They will reflect back in the direction where they came, or they will refract to one focal point. Okay. So concave lenses, remember the ones that go inwards, are going to cause light to disperse or diverge away from each other. In contrast, your convex lenses are going to cause light to converge, move together, okay? And so they will not maintain a parallel relationship, remember, because of Snell's law, because there's a different density of the lens and light traveling through air. And they're not going to reflect back in the direction that they came from, because that would be just a mirror, a reflective image. Okay, so the answer is B. The light rays will diverge away from each other. Okay, that's what a concave lens does. A convex lens, on the other hand, which is this one, would focus light at a closer point. Okay, so this is dispersing, this is focusing. Oops, I gave you guys the answer to this one, didn't I? Well, it's okay. Let me pause the sharing, because haram, I don't want you guys to get the answers to everything just now. I mean, you got the answer to this one, but oops. Okay. I might as well fix the next one while we have time. Okay. Lovely. Okay, guys. Resharing screen. There we go. So I really hope you skipped forward and pretended that you didn't just see the answer. So I'm going to ask a question again. Okay. The condition of hyperopia is caused by which anomaly of the eye? So remember, hyper people love to run away, and I find them annoying. Sorry, guys. Okay. So the condition of hyperopia is caused by which? So decreased production of melanin. Didn't mention anything about that. Uneven curvature of the cornea. No, that's astigmatism. An eyeball is shorter than normal or longer than normal, or a lens system that is too powerful and focuses the object in front of the retina. So remember, hyperopia, okay, likes to go far. So that means that the eyeball itself is shorter. You're focusing the image behind the retina. That's why you can't see it. And so that's why C is the answer. D and E are actually describing hyperopia, okay? And this is the picture that you weren't supposed to see. Okay, so axial length of the eye is too short for the refractive power of the cornea and lens. This is hyperopia, meaning they are far-sighted, and you correct it with convex lenses. Now let's go back to this question. Okay, here we go. Condition of myopia, on the other hand, is corrected by which type of lens? Compound, convex, spherical, concave, or cylindrical? Okay, compound lens, you use what I mentioned when you have like an astigmatism and something else. Okay, convex lenses, remember, they focus things closer. Myopic patients already have really big, strong eyes, so you don't want to focus something closer. You want to make it go further. So spherical lens is just generally describing the different types of convex and concave. But concave, remember, that's what we just asked in the previous question. It disperses light further, meaning it will help in a myopic patient. And cylindrical lens is used for astigmatism. So the answer here is going to be concave lens, okay, for myopia. Remember, myopia, I like to keep my things close to me, okay? So myopia, close, meaning it's going to focus it before the retina, okay? And my thing, so like imagine yourself going inwards, it's concave, you're caving in, okay? So that's the whole lecture. I hope you guys found it beneficial. I hope this explained the key concepts for you and that you understand why you need glasses if you have an astigmatism like me, and why your parents end up reading things like this over time. So inshallah, you benefited from this. If you have any questions, you can email me. You guys can talk to me on whichever platform. And oops, I'm sharing on 2 screens. That's why I think it's a bit slow. Okay, there we go. So thank you guys for tuning in, and Allah يوفقكم وييسر أمركم, and you got this. You're almost done with second year, which is super, super exciting. خلاص, third year. Inshallah, it'll be over soon, and then you guys are gonna go to the hospital. And I'm very excited to see you, and have a lovely day. مع السلامة.